And now it's my great pleasure to welcome Andrew Cuff, who is also a dear colleague of mine. He's the Clinical Director for Community Service Division at Cora Health, where he plays a central role in the development of and execution of our clinical strategy. So he's accountable for clinical quality, innovation, and is also an ex-army officer, which I didn't know until today, having previously commissioned into the Royal Yorkshire Regiment. Yeah?
Yorkshire.
That's right, Yorkshire, yeah. And he's also a runner.
Average.
Average, he says. So the floor is yours.
Thank you very much. I think so.
Yeah, good.
There we are, happy days. Ian's gratefully left me about 10 minutes, so I'll rustle through. But what I can't do is promise you any Star Wars references and definitely no 90s hip-hop with profanities. But what I can talk to you about is shoulders, but I'm not quite sure why the slides are moving. There we go, crack on from there. So, I don't know if does that work pointer-wise a little bit? So I always like to talk about Yorkshire when I come abroad because the Yorkshire Tourist Board won't allow you to leave the country otherwise. But before I do, I just want to say thank you to the organisers for the opportunity to contribute to what is really a brilliant conference programme. And I think you all agree that the last 2 days have been full of wisdom and insight, and it's a real privilege to present amongst such esteemed colleagues. So, as mentioned, Yorkshire is that little blob of red. Hopefully that works somewhere there. And thankfully, Yorkshire's 2 hours by 2 hours, and Ian and I live about 5 minutes away from each other, where that green and red blob meet. So that's where we're presenting from this morning. So when I was approached last year, I was asked to deliver a talk on differentiating neck pain from shoulder pain, a question that has had immense focus over many years with many trials, many opinions and tests, all looking to tease out this nuance. Is this person's arm pain coming from their neck, or is their arm pain coming from their shoulder? But my first response, in a conference themed about structure and function, was, does it matter? So what if it's neck-related or shoulder-related? And speaking as a physiotherapist, does that change what we do with the person in front of us? So I want to do a quick show of hands, if I can. If someone is presenting with shoulder pain, arm pain, is it important to differentiate between neck and shoulder? And if you think the answer is no, can you put your hand up? My 2-year-old has put her hand up, so that's brilliant. We've got one. Okay, so I've got a little bit of work to do. So on the next slide, I'm going to answer the question, does it matter? If you don't want to know the answer, look away now. It depends. Now, of course it depends, but that's an easy answer, isn't it? So over the next 20 minutes or so, or probably 10 minutes or so now, I'm going to argue the position that it does not matter if we determine whether arm pain is neck-related or shoulder-related. This is my disclaimer slide, because I'm sure some of you are sitting there thinking, crikey, this guy's not safe. Well, in situations where there is serious pathology, such as an osteosarcoma, then of course it matters. Or in situations where you're considering invasive treatment, surgery or injection, then of course it matters. Or in situations where there's specific pathology, such as a traumatic dislocation, of course it matters. And as an Englishman, it wouldn't be a talk without a cricket photo. And this here is Chris Wokes in the summer just gone. He, on the first day of a 5-day test match, a cricket match, he fell onto his shoulder, playing against India, and dislocated his shoulder. And he had to go off the pitch, and he couldn't bowl, and that's him going off the pitch there. More on him a little bit later. But does it matter, speaking as a physiotherapist or a rehab professional, in the majority of our patients? And as I've outlined, in this talk, I'm going to argue no. And my aim is to convince you that it does not matter. Now, the majority of people that present to us do so without trauma, without specific pathology that we can reliably detect, and without the need for invasive intervention. And as such, I'm going to outline a position that suggests it doesn't matter if it's shoulder or neck related in this context. Now, this is a scientific conference, so I appreciate and have outlined there are times where, of course, it does matter. But let me just play this out, this thought exercise, and ask you to reflect, but what if it didn't? Now, in preparation for this talk, and having grappled with this question for many years, I thought I'd explore what wider opinion was. So I put this tweet out, and 96% of people thought it was important. And I must say, I was hoping for a little bit more support than 4%, but if you couldn't see the show of hands in the room, I've got less than 4% in the room, so maybe I should have stopped there. But then I reflected, and I thought, well, maybe it's Twitter, it's Elon Musk, it must be the algorithm. So if I ask this question on LinkedIn, where people are clearly more professional, surely I'd get more support. And the answer was, nope, I got even less. So 2% of people agreed with me on there. And Owen, who's a great physiotherapist and an even better person, thought I was asking a trick question. Well, that didn't quite go to plan, so I've clearly got a lot of work to do this afternoon to convince you all. So it got me thinking. If we're differentiating between neck-related arm pain and shoulder-related arm pain, in those without trauma, without concerns for serious pathology, and we're considering physiotherapy management, well, what then must be true? Well, we'd want to be confident it was either neck or shoulder, and from here, you want a level of consistency in terms of how this was achieved by clinicians, and you would hope then that treatment directed at the source looked different depending on whether it was neck or shoulder-related, and resulting in better outcomes. So I'm going to explore each of these in turn. So we start with the ability to reliably and with confidence differentiate neck and shoulder pain. So is it the neck? What might we look out for when determining if arm pain is related to the neck or not? We may look for where the symptoms are. We may look for a description of the symptoms, any suggestion of nerve root or neural involvement. We may look for clues in the mechanism of onset or factors that make the symptoms flare up. For example, when neck or shoulder movements are combined, a tennis serve or painting the ceiling or reversing the car. And of course, there are a plethora of things we could look at objectively, but are they any good? Now, area of location can be helpful. Do you have pain between your shoulder blades? Do you have pain in the region where a backpack strip would set? And this is the seminal research from Cloward and Murphy. And for those of you who don't know about Cloward zones and how we got this descriptor, Cloward looked at some medical students, it's always medical students, he anaesthetized them, and he attached some coloured string to each disc. So C4 had red, C5 had green, etc., etc. When those medical students woke up, they had string coming out of their mouth, and he would pull the string and say, does that hurt? And if so, where? And what you can see here is mostly across the medial border of the scapula. Whereas Murphy, a bit more recently, looked at injecting hypertonic saline into the nerve roots, again, medical students, and said to them, does that hurt? And if so, where? And what you can see from the nerve roots is, again, the medial border of the scapula. Now, I've mentioned there's a plethora of clinical tests. I've just chosen one here to work out is it neck-related or shoulder-related. So this is the Sperling's test, designed to whether or not the symptoms are related to a nerve root. So you have a sensitive test is your true positive, a specific test is your true negative, and the pooled data suggests that the Sperling's test is more specific than sensitive. And this is uncommon in the literature, where tests are more typically sensitive. So in someone with arm pain with a positive Sperling's, that might be suggestive of a more neck-related cause. Combining this with something such as a negative Hawkins-Kennedy, a more sensitive test, may also give you some clinical tools. The problem arises, however, when we look at reliability. If I see the same person twice, would I get the same answer? If I saw the same patient as Ian, and Ian applies the tests, and then I apply the tests, would we get the same answer? And for a test to be deemed reliable clinically, it needs to demonstrate greater than 70% reliability, or greater than 0.7. So 7 out of 10 times, I would get the same result as Ian, or I would get the same result if I applied the test twice. And unfortunately, for all shoulder tests and for the Sperling's test, this reliability threshold is not reached. 13% for Sperling's and 39% for Hawkins-Kennedy. So 1 in 10 times, Ian and I might agree. So let's look at consistency. So reliability and confidence is a bit mixed, but how are these ideas and concepts applied in practice? Now, this is a cool study. the authors undertook a systematic review of randomised control trials that were determining the effectiveness of treatment for shoulder pain. The logic being, if you wanted to test the treatment for shoulder pain, you wanted to be sure that all of those in the randomised trial indeed had shoulder pain. So this systematic review looked at how the authors ruled out the neck prior to onboarding the patient for their research. And the results are fascinating. 3/4 of studies didn't look to rule out the neck, or relied upon symptom location only, while 4 studies merely excluded people that had a previous neck surgery. Now, only one person in the room put their hand up and said it wasn't important, and she's 2. But the research suggests that 20% of colleagues do not feel it's necessary to rule out the neck when looking at treatments for the shoulder in randomised research. There was considerable variability rather than consistency in the application of concepts. Now, that paper was in a research setting, and following on from that systematic review, we undertook a survey looking at what do clinicians do in practice, and we had just under 1,000 clinicians respond. And the results were again fascinating. 20% of clinicians would not look to rule out the neck in someone presenting with shoulder pain. The majority, if they were to look at examining the neck or trying to rule the neck out, would do so by moving the neck and seeing if it reproduced symptoms. But after this, results demonstrated real variation in practice. So reliability and confidence, bit of a mixed bag. Application in the research setting and a clinical setting demonstrated wide-reaching variation. But what about guiding specific treatment to deliver better outcomes? Now, if we look at manual therapy, and we apply manual therapy to the cervical spine, in those with non-traumatic shoulder pain and in those following shoulder surgery, this results in improved shoulder pain, improved range of motion, and less disability. So if we treat the neck, when the person's arm pain was rated to the shoulder, we can still expect to see some improvement in outcomes. Now, the exercises on the screen here are a condensed list of those included in the exercise intervention of a randomised trial, determine the effectiveness of specific exercises in those with neck pain. And these are the specific neck exercises. They include scapular focus exercises, large compound movements of the shoulder that you'd expect to see in a shoulder rehab program. So what's the conclusion? Well, specific neck rehab looks a lot like shoulder rehab. Now, the exercise here are a condensed list of those in an exercise intervention of a randomised trial, determine the effectiveness of progressive shoulder-directed exercises for those with shoulder pain. These are the exercises. You can see scapular focus exercises, large compound moves of the shoulder, just like the slide before, and they include cervical and thoracic exercises. So what's the conclusion? Progressive, specific shoulder rehab looks a lot like neck rehab. So it begs the question, is specific treatment even needed for those with arm pain? Well, this systematic review demonstrates there's insufficient evidence to suggest that specific exercises outperform general exercises for those with shoulder pain. So maybe we should stop worrying if it's neck-related or shoulder-related and support the person to go more active, go for a walk, go for a run, cycle. But there's a big piece we might potentially be missing. We don't treat arm pain. We treat people with arm pain. And athletes are people too. A human being with thoughts, beliefs, worries that we increasingly recognise are important to good health and good musculoskeletal health. And staggeringly, only 20% of our health is related to access of care, quality of treatment received, or quality of care received. The remaining 80% of treatment outcome is largely determined by societal factors, the physical environment somebody lives in, their wider health behaviours, their socioeconomic status, all potential positive and negative influences for an athlete. And these factors form a significant part of Jeremy Lewis's recent publication, where he outlines the signals we need to progress beyond specific exercise and adjuncts such as manual therapy, the factors that make up the 20% of a treatment outcome, and instead think about how we support the person to enhance the other 80%. And on the diagram here, you can see 8 segments, and only 2 of them, the top right-hand side, might be related to what we may consider traditional physiotherapy intervention. The majority, the other 6, focus on wider holistic aspects of health, all of which are also essential to high performance. And maybe this is where we need to get better. Maybe these are the things that matter. And as Peter and Fiona outlined yesterday morning during the conference opening, athletes are not immune to these factors. They are people too. So to wrap up, earlier I outlined what I thought had to be true for differentiating neck-related pain from shoulder-related pain, once trauma, serious pathology and invasive intervention were ruled out. The data is clear. We can't confidently determine if something is neck-related or shoulder-related. There's wide variation in practice, both in research and clinically. Shoulder rehab looks like neck rehab, and after all of that, our traditional physiotherapy treatment probably only accounts for 20% of patient outcomes anyway. And if I haven't already convinced you, I mentioned Chris Wokes earlier on in my talk, and this was him falling on his shoulder, sustaining a traumatic dislocation and leaving the field on a Thursday evening. And this is him batting on the Monday morning with one arm in a sling. And that, I think, demonstrates, does it really matter if it's neck-related or shoulder-related? Now, to wrap up then, I asked you earlier to show your hands if you thought it wasn't important to differentiate neck and shoulder pain. I want to see if I've convinced at least one of you that that might not be the case. So if you're sitting there now and thinking, do you know what, I don't think it's important to differentiate neck from shoulder, please raise your hand. Hey, that's not bad going, is it? What if I ask you who maybe thinks it wasn't as important as they maybe did 10 minutes ago? I'll take that. But, as I said, does it matter? Well, it does depend, just probably not as much as we first thought. Thank you.
Thank you, Andrew. That was quite enlightening. So we have time for one or two questions. Do you have some? No?
I think we got away there.
No question at all? So you were no, I just have one. You were talking about serious pathologies. You know, all the nerve gliding stuff is really popular here. What do you think about it? You know, like about, you know, this
I see.
pain in the arm and...
Please.
Yeah.
So I think the question is, what do I think of nerve gliding exercises?
Yeah.
They're not something I use in my practice. I used to use them a lot. But particularly the patients that I worked with, they found it quite difficult to get the coordination of what should be moving when. And we bring that back to first principles. Nerves are bloodthirsty, they like movement, and they like oxygen. So I get my patients moving their arm, and if that's too sensitive, I might get them doing some aerobic exercise. And I suspect, and particularly my outcomes would suggest, there's no real difference between a more general approach that gets the arm moving, gets the nerve moving, encourages that blood flow and oxygen flow, as opposed to doing specific exercises. So I've moved away from using them more in favour of kind of general movements and exercise as opposed to real specific neural glider exercises they were once described.
Thank you. And just one for Jan. Do you think in rugby it matters if it's neck or shoulder?
I think in rugby players, certainly the guys we saw in the scrum from there, most of their necks, by the time they're in their mid-20s, look like a 70-year-old neck from there. So again, it's what we're looking at is function with it, and we want them to do as much as you can as a 20-stone prop, have beautiful, effortless, pain-free movement.
That was quick. Thank you.